Hello everyone, welcome back to my YouTube channel. My name is Dr. Hamid, and in today's lecture, we will talk about hematopoiesis and everything you need to know about neutrophils. Okay, so let's first talk about hematopoiesis. This will not take a lot of time, it is very simple. So, we know that multipotent stem cells are present in the bone marrow. Okay, all of the hematopoiesis happens in the bone marrow. Okay, so this is a single cell multipotent stem cell. Multipotent stem cell either go towards either becomes myeloid stem cell or it becomes lymphoid stem cell. From the name, it is very clear that the lymphoid stem cell will undergo lymphopoiesis and will produce lymphocytes. Okay, and from the myeloid stem cell, it will either undergo erythropoiesis or thrombopoiesis or granulocytopoiesis or monocytopoiesis. Okay, so multipotent stem cell undergo becomes myeloid stem cell and it becomes lymphoid stem cell. Myeloid stem cell, when undergo erythropoiesis, they produce erythrocytes, also called RBCs. Okay, if they undergo thrombopoiesis, it will produce platelets. Okay, if the myeloid stem cell undergo granulocytopoiesis, it will become either eosinophil, basophil, or neutrophil. Okay, their pictures, these drawings, these are very important to differentiate which type of cell it is. Okay, if the myeloid stem cell undergo monocytopoiesis, it produce monocytes which then become macrophages. Okay, then the other lineage is lymphoid stem cell. From the name, it is very clear they will undergo lymphoid stem cell will undergo lymphopoiesis and they produce B lymphocytes and T lymphocytes and natural killer cells. B lymphocytes then become plasma cell. T lymphocytes further divides into helper T cell or the cytotoxic T cell, and the third one is natural killer cell. Okay, very simple. Now let's talk about neutrophils. What are neutrophils? We know that when the myeloid stem cell undergo granulocytopoiesis, they become these myeloid stem cell when undergo granulocytopoiesis, these myeloid stem cell become myeloblast. Okay, and these myeloblasts either become eosinophil or basophil or they become neutrophil. Okay, you can see the difference between these three cells. Eosinophil, they are red in color and they have a nucleus like headphone. They have a headphone like nucleus. Basophil, they are purple in color with some types of granules in there. And neutrophils, you can see they are multi-lobed. They are not like headphones, okay? One, two, three, four, some kinds of um, different lobes. They are multi-lobed, okay? So the neutrophils, look at the image A. This is neutrophil, multi-lobed nucleus. Neutrophil has multi-lobed nucleus. Okay. Eosinophils are usually bilobed. They are like headphones. Okay. So neutrophils are multi-lobed. These are the acute inflammatory response cells. They are phagocytic. They cause phagocytosis. Okay. They have multi-lobed nucleus. From whenever you see a cell with a multi-lobed nucleus, you should always consider it neutrophil. Okay, so these neutrophils have specific granules called these specific granules contain leukocyte alkaline phosphatase. These are the enzymes. They contain collagenase, lysozyme, and lactoferrin. They also have azurophilic granules that contain these azurophilic granules contain enzymes like proteinases, acid phosphatase, myeloperoxidase, and beta glucuronidase. Okay, these all enzymes work in the inflammatory reactions. Okay, so normally when we see neutrophils in the circulation, they are multi-lobed nucleus. Okay, normal the normal neutrophil is different from the reactive neutrophil. Okay, reactive neutrophils are those neutrophils which we see at the time of inflammation. Whenever in the body there is an inflammatory state, whenever there is a bacterial infection, we'll see a large number of neutrophils in the circulation. There will be neutrophilia. When you see increased number of neutrophils in the blood circulation, we call it neutrophilia. Okay. And when we see those neutrophils during inflammatory reaction in the body, during inflammatory states in the body, these neutrophils are reactive neutrophils. They are slightly different from the normal neutrophils because they have certain granules, certain characteristic features which we don't see in the normal neutrophils. Okay, so during inflammatory states, first we see neutrophilia. We see increased number of neutrophils in the circulation, increased number of neutrophils at the site of inflammation. There will be neutrophilia. Okay. Second, we see a change in neutrophil morphology. Okay. Whenever I'm repeating again and again, whenever there is an inflammation, we'll see large number of neutrophils at the site of inflammation. We call it neutrophilia. Second, we'll see a change in neutrophil morphology. Okay, and those neutrophils are called reactive neutrophils, and these neutrophils have toxic granulation. Look at the image B. They have toxic granulation. These are dark blue coarse granules. Okay, they also have dull bodies. These are light blue peripheral inclusions. Look at the arrow, dark black arrow. This is showing the light blue peripheral inclusion. These are dull bodies. So dull bodies and the toxic granulations you will not see in normally in the neutrophils. You will see only in the reactive neutrophils, and then you will see cytoplasmic vacuoles as well. Okay, and this is how um, the reactive neutrophils are different from the normal neutrophils. Okay, reactive neutrophils are those neutrophils which we see at the time of inflammation. Okay, and along with that you will see left shift. So during the time of inflammation you will see neutrophilia, you will see a change in neutrophil morphology, and you will see left shift. Now what is left shift? Here, this is left shift. What is left shift? Increase in neutrophil precursors. Okay, precursors mean um, you will see band cells and you will see metamyelocytes. So neutrophil undergoes certain processes to become adult neutrophil. Whenever there is an inflammatory state, you will see the left side, you will see the neutrophil precursors. You will see the adult neutrophils, but you will see increased number of neutrophil precursors more than the adult neutrophils, okay, in the peripheral blood, in the peripheral circulation. Okay, that reflects the increased myeloid proliferation, example inflammation on chronic myeloid leukemia. Okay, now there are certain agents, certain, for an example I can say there are certain people that helps neutrophil to come to the site of inflammation, to come to the circulation. So there are certain chemotactic agents, chemotaxis factors that bring neutrophil to the site of inflammation, and these chemotactic factors are C5a, interleukin 8, LTB4, 5-HTHEDE, these are leukotriene precursor, kallikrein, platelet activating factor, and N-formylmethionine bacterial proteins. Okay, so these are the agents that bring neutrophil to the site of inflammation. They help neutrophil to come to the site of inflammation. So these are called neutrophil chemotactic agents, and these agents are very important. Memorize these all agents by your heart because they are very important. They ask a lot of questions about these chemotactic factors. They ask you which one of these is the chemotactic neutrophil chemotactic agent. They can ask C5a or interleukin 8 or LTB4. Okay, so remember these neutrophil chemotactic agents. Now let's talk about hypersegmented neutrophils. What are hypersegmented neutrophils? I've already told you that neutrophils they have multi-lobed nucleus. Okay. Now what are hypersegmented neutrophils? Hypersegmented neutrophils are those neutrophils, the neutrophils, um, these are called in the simple words, if the nucleus of the neutrophil, okay, if the nucleus of the neutrophil has six or more lobes. If the nucleus, I'm repeating it, if the nucleus of the neutrophil has a nucleus, okay? If every neutrophil has a nucleus, okay? So if the nucleus of the neutrophil has six or more lobes, usually the neutrophils has four or five lobes, okay? But if the nucleus of the neutrophil has six or more lobes, this type of neutrophil is called hypersegmented neutrophils. Okay, now the question arises, when we see this type of neutrophil, when in which condition we see hypersegmented neutrophils? Just remember one answer: whenever there is a megaloblastic anemia. Only in the megaloblastic anemia, which is due to vitamin B12 or folate deficiency, you will see hypersegmented neutrophils. So hypersegmented neutrophils, the neutrophils that has six or more lobes, they are associated with megaloblastic anemia, either due to vitamin B12 or folate deficiency. Okay. Non-megaloblastic anemia, okay, non-megaloblastic anemia due to chronic alcohol use or liver disease, we don't see hypersegmented neutrophils. So hypersegmented neutrophils are only associated with the megaloblastic anemia, not with the non-megaloblastic anemia. Okay, and the megaloblastic anemia is due to folate or vitamin B12 deficiency, and non-megaloblastic anemia is due to liver disease or chronic alcohol use. So we will see hypersegmented neutrophils only in megaloblastic anemia. Okay, now here they don't you don't see neutropenia, but again neutropenia is very important topic which is related to neutrophils. So I will talk about it. Okay, so we have already talked about neutrophilia. Whenever there is an increased neutrophil count, okay, is neutrophilia. When there is a decreased neutrophil count, it is called neutropenia. Okay. Now, what is the definition of neutropenia? When the absolute neutrophil count is less than 150 cells per millimeter cube. I'm repeating it. When the absolute neutrophil count is less than 150 cells per millimeter cube, we call it neutropenia. This is the definition of neutropenia. And how we calculate absolute neutrophil count? Absolute neutrophil count is equal to WBC count into percentage of bands plus percentage of segmented neutrophils. This is how we calculate absolute neutrophil count. Okay. What are the causes of neutropenia? What are the factors that could lead to neutropenia, that could lead to absolute neutrophil count less than 150 cells per millimeter cube? So it could be due to decreased production of neutrophils, number one. Number second, it could be due to migration of neutrophils away from the circulation. That will also lead to neutropenia. Or it could be due to increased destruction of neutrophils, or it could be due to increased utilization of neutrophils in infections or any inflammatory condition. So these are the factors that could lead to neutropenia: decreased production, increased destruction, increased utilization, or migration away from the vascular space. Okay, these are the factors that could lead to neutropenia. In which conditions we see neutropenia? Usually we see neutropenia in infections. Okay, because we are utilizing increased number of we are utilizing more neutrophils. Second, we'll see neutropenia due to certain drugs can lead to neutropenia. Or we can see neutropenia in the diseases that infiltrate bone marrow space. Whenever any disease that infiltrate the bone marrow space, they are infiltrating the space in which neutrophils are formed, in which in the space of the bone marrow where neutrophils are produced. So the bone marrow will produce less number of neutrophils. For example, in leukemias and lymphomas. Leukemias and lymphomas are the conditions where the bone marrow is infiltrated uh, by the by the malignant cells. So there will be neutropenia. Okay, whenever there is neutropenia, whenever there is decreased neutrophil count in the circulation, so it will increase the risk of sepsis due to Staph aureus, Pseudomonas, Proteus, Klebsiella. Okay, so whenever there is neutropenia, the sepsis due to Staph aureus, Pseudomonas, E. coli, Proteus, this will increase. Okay, how we diagnose neutropenia? We do CBC. Whenever there is any blood condition, we'll definitely do the CBC. CBC with the peripheral smear, where we'll see decreased neutrophil count. Okay, how we treat neutropenia? What are the treatment options we have for neutropenia? So it is very important to see what kind of drugs a patient is taking. Either the patient is taking a drug that could lead to neutropenia, so we should stop that drug first. Okay, because there are certain drugs that could lead to neutropenia. So if a patient is taking that particular drug, we should first stop that drug to prevent neutropenia. Second, due to neutropenia, due to decrease neutrophil count in the circulation, it can lead to neutropenic fever. And whenever there is a fever due to neutropenia, neutropenic fever, we give patient a broad spectrum antibiotics, for example, cefepime, a fourth generation cephalosporin. Okay, and what we can do, we can give patient hematopoietic stem cell. The third option is we can give patient hematopoietic stem cell factors like granulocyte colony stimulating factor, example filgrastim. ठीक है? Okay, that can be used to shorten neutropenia. Okay, so there are three options how we can treat neutropenia. The first is if a patient is taking drug, first stop that drug that is causing neutropenia. Second, if a patient has neutropenic fever, give broad spectrum antibiotic. Third, give patient granulocyte colony stimulating factor like filgrastim. Okay, so this is all about neutrophils, and here I also want to show this image. I was talking about reactive neutrophils. Reactive neutrophils, look at this image. Okay, so these are the reactive neutrophils. Both diagrams are showing reactive neutrophils. The first is they are showing toxic granulations. They are showing light blue dull granules. Okay, and these are cytoplasmic vacuoles. These toxic granules, dull bodies, and the cytoplasmic vacuoles we only see in reactive neutrophils and not in normal neutrophils, which we see normally without an inflammation. Okay, so this is all about neutrophils. If you guys have any question, you can ask me in the comment section. Okay.